Good afternoon, everyone, and welcome to this edition of AFTD's Healthcare Professional Education Series, Treatment of Behavioral Variant FTD. I'm Will Reiter, AFTD's Education Program Manager, and I want to thank you for joining us. As many of you know, currently there are no approved disease-modifying treatments for any of the FTD subtypes, including bvFTD. We certainly hope that that changes soon, but in the meantime, for today's program, our speaker will focus on treatments and interventions that can be successful in managing bvFTD symptoms. Before we begin, I just want to share a few housekeeping items. Everyone will be muted throughout this webinar to keep background noise to a minimum. If you have any technical issues, please write a message into the questions box and we will do our best to assist you. Additionally, along the way during the webinar, please use the questions box to ask questions so that time permitting, there will be a Q&A segment at the conclusion of the presentation. This webinar will be recorded and archived for later viewing on AFTD's YouTube page. And you should also know you can view our previous webinar, Differentiating bvFTD from Alzheimer's and Other Disorders, a program which focused on diagnosis. You will note that our AFTD 2023 Education Conference is coming up soon in just 3 weeks on May 5th in St. Louis, Missouri. Our annual education event convenes persons affected by FTD, their families, experts in the field, other healthcare professionals and researchers for a full day of FTD-focused education and connection. If you can't make it to St. Louis to join us in person, you can still register to join the free live stream, and virtual attendees will be able to access all of the plenary sessions and view whatever you like, which includes our keynote speaker, Dr. Bruce Miller, the director of the UCSF Memory and Aging Center, an internationally respected FTD expert. Visit our website at the URL located at the bottom of this slide to learn more and to register. AFTD has a strong initiative focusing on partnering with healthcare professionals, and one of our resources is our Partners in FTD Care e-newsletter, which is specifically geared and targeted to healthcare professionals. Each issue of Partners takes a deep dive into a particular FTD disorder or specific aspects of care. On the slide, you can see recently we produced a Partners in Care issue on FTD and genetics. In the center, an issue specifically for healthcare professionals on how to best support families after a diagnosis. And on the right-hand side, an issue focusing on facility-based care and helping individuals to transition into facility-based care. There are over 30 Partners in FTD Care issues, and you can access any of them at the URL at the bottom of this PowerPoint slide. Now on to some of the details. If you are interested in submitting for credit, we're very appreciative that Rush University provides credit for watching this live webinar. Tomorrow, you will receive an email explaining how to apply for credit. Know that you have 10 days from the date of today's activity to complete the evaluation and to claim credit. The learning objectives for the program today, you should be able to list 2 treatments that can be effective with bvFTD symptoms. You should recognize the potential adverse reactions to psychotropic medications, and you should be able to describe the value of non-pharmacological interventions for a person with bvFTD and their family caregivers. Additionally, I want to mention that you should have a handouts section likely on the lower right-hand side of your screen. If you click on the triangle next to handouts, you will see a number of supportive materials, including an excellent article by today's speaker. Before we get to today's speaker, we are going to ask a couple quick polling questions to give our speaker a sense of who is in today's audience. Our first polling question is, have you ever prescribed or provided treatment to a patient with bvFTD? Please select only one of the answers on the screen, and my colleague, Matt Ozka, will provide us with the percentages of people that answered these choices.
Okay, it looks like we're at 62% said no, 19 said a few times, 16 said many times, and 3% said once.
Okay, so that means we have quite a number of people who have not ever worked in terms of treatment for a patient with bvFTD, and then a mix in relation to some of the answers. That's very helpful. So now we'll move on to our second polling question, which relates to bvFTD symptoms. And the question is, which of the following bvFTD symptoms do you think would be the most difficult to treat? So again, you can only choose one. We'll give you a few seconds to do that. And then Matt will share your responses.
Okay, we're at 32% said behavioral disinhibition, 25% said apathy or inertia, 18% said compulsive or ritualistic behavior, 14% said psychosis, and 11% said agitation.
Okay, so Dr. Ducharme, you have your working orders there in terms of what's really of interest to our audience, although all of those symptoms can be challenging. So I'm very pleased to introduce today's presenter to you. Dr. Simon Ducharme is a neuropsychiatrist and a clinician scientist at the Douglas Mental Health University Institute and the Montreal Neurological Institute. He specializes in FTD and the interface between psychiatric disorders and dementia. His research program uses advanced neuroimaging techniques and other tools to develop diagnostic biomarkers for FTD, which is critically important in terms of moving forward on treatment, on diagnosis, on testing treatments. So we wish him success with that continued work. Dr. Ducharme is the director of the McGill Division of Geriatric Psychiatry and Neuropsychiatry. And finally, I'll mention he is the director of the American Neuropsychiatric Association Committee on Research. We'll welcome Dr. Simon Ducharme to join us live, to come on screen and to unmute, and then to share his presentation slides with you. And I do see your slides, Dr. Ducharme, and there you are. So I will let you take it away, and I'm going to mute myself and go off screen. Thank you.
Very good. Just don't want to make a mistake. Can I close the control panel so I see my own full slides, or will that remove me from the meeting?
Yeah, you should be able to kind of move that window if that's easiest.
Okay, cancel. Let me see if I can maybe shrink it.
Or minimize it, yes.
Okay, there we go. Good afternoon, everyone. So I'm delighted to present to you today on the very important of treatment of behavioral variant frontotemporal dementia. So we'll be going over this topic for about 30-40 minutes, leaving a question period at the end. Before we start, I had the usual disclosure. So I do significant research work in the field of dementia, including some clinical trials with pharmaceutical companies. There are none of these relationships that relate to what will be discussed in today's presentation. So we'll start by a brief clinical overview of FTD syndromes. I really want this to be focused on the treatment piece, but I just wanted to make sure that everyone had a shared understanding of the basic aspects of what is behavioral variant FTD. Then we'll go in a sequence of steps through the aspects of prevention of dementia, behavioral approach to the management of symptoms in FTD, and finally, pharmacological treatments, both what we currently have access to and what we can expect in future research developments. So to understand FTD, you have to view this as a cluster of disorders. So it's part of an entity we call frontotemporal lobar degeneration. So that's a pathological term. So FTLDs are diseases we see under the microscope that can present in terms of symptoms in different ways. The most common one is what we call frontotemporal dementia, which is commonly shortened to FTD. Within the FTD, we have two major classes of presentation. We have the language variant called the primary progressive aphasias. So these are diseases in which the first symptom that we see changing is issues with producing speech or understanding speech. And the other major group are the behavioral variant FTD, which is the presentation in which we see mostly symptoms in terms of behavior, personality changes, cognitive changes. So that will really be the focus of today's talk. I'm mentioning that there is also a slightly more unusual variant of the behavioral FTD called a right temporal lobe variant. I'll show you quickly how symptoms can be slightly different from the behavioral variant FTD. These clinical syndromes are associated to dysfunction and shrinking in the brain. So the shrinking in the brain we call atrophy, and we will usually see a behavioral variant of FTD when most of the damage in the brain is in the front part, so what we call the anterior frontal lobes, or in the front part of the temporal lobe. So if you look on the top left, you can see that around the brain at the higher level in the frontal lobe, the brain is shrunken. You see a lot of black, so that's the liquid taking the space. So this is abnormal shrinking in the frontal lobe, and this is what causes the behavioral changes. When you have a language variant, you tend to have changes in the brain in other areas like the left temporal lobe or more posterior areas of the frontal lobe. But if you have damage in the anterior part, the part in the middle, you get behavioral changes. So what does it look like concretely? So these are patients who will present with some degree of cognitive changes. So usually they have impaired attention, they have difficulty organizing themselves. We call that executive dysfunction. It's something that appears insidiously. So that means there's not a clear-cut day at which the disease starts. It's a slow, gradual process over time that gets worse, and that will cause a cluster of behavioral symptoms. So the ones we have in diagnostic criteria are behavioral disinhibition. So this means lacking filters, saying inappropriate things, losing manners. The other big one is apathy. That's a decrease in motivation, initiative to do things, interest. There can be a loss of sympathy or empathy. So that's generally decreased emotional interest in other people, leading to withdrawal, disengagement from the family. They can have perseverative, stereotype, or compulsive behavior. So these are either simple movements like rubbing fingers or rituals that can be more complex, like needing to follow a very strict schedule, for example, always taking the same walk at the same time in the same order. And finally, hyperorality, that's most commonly craving for sugar. So eating a lot of sugary food or fatty food, can be increasing alcohol or smoking. So we see these symptoms with some degree of cognitive decline, and it gets worse over time. And it's not better explained by other psychiatric disorders like depression or other dementias like Alzheimer's. The right temporal variant is a slight variation. So this is a disease in which most of the damage is in the right temporal lobe as opposed to the frontal lobe. So they do generally meet the criteria for bvFTD, but they have usually a lot of compulsion. So they do rituals very intensely. They have difficulty recognizing other people's emotions, sometimes recognizing their face. They can be irritable. Usually in both of these diseases, there's a fairly marked loss of insight. That is, the person does not realize that they're getting sick. Sometimes in the right temporal variant, there can be partial awareness, but usually fairly minimal. I won't go in details over the language variant we call the primary progressive aphasias. There are two major forms, one in which the person loses what we call single word comprehension and object knowledge. So their brain loses the understanding of words and how they relate to specific objects. So these people have difficulty expressing themselves. The second variant is when it's more the rhythm of speech. So the speech gets what we call agrammatic, so it gets simplified, slower, broken. In both of these diseases, yes, you see mostly changes in language, but you can also see changes in behavior. The language is how it presents, but it will progress in the brain and they will eventually have some degree of behavioral symptoms. So we'll be discussing bvFTD, but a lot of it applies also to patients with PPA who can also have some degree of neuropsychiatric symptoms. Who can be suffering from FTD? So it's usually a young onset dementia. So the peak is between 45 and 65. We can see some younger cases. It also exists in older adults. We don't recognize it as much in older adults because there's so much Alzheimer's and vascular dementia that they tend to be a bit hidden in the enormous amount of patients with dementia. Is this a common disease? No, it's a relatively rare disease, but it's common enough to be a major health problem. It's common enough to be encountered in all memory clinics. So I gave you here the annual incidence. So incidence is the number of new cases per year. So depending where you live, that gives you a sense of how many cases there are in the population. And what causes FTD? There's both a very strong response, which is genetics, but that's in 20% of cases. So about 1 in 5 patients, sometimes a little bit more, we find one mutation that is responsible for the disease and that can be passed to other family members. But that leaves 80% of patients for whom we do not know why they're developing FTD. So we call that a sporadic disease. And as opposed to Alzheimer's, for which we do have a lot of known risk factors, in FTD, we really have no currently identified environmental risk factor that we can intervene on. There's some studies looking maybe at concussions, that they could make symptoms appear faster, but it's a pretty mild finding. FTD can have different pathologies. So it means that in the brain, not all patients with behavioral FTD have the same changes in the brain. I'm going to throw some words here, but there's some patients that have tau, some that have TDP43. These are different forms of abnormalities that can accumulate in the brain. It doesn't change much in terms of symptoms, but it's very important in terms of developing treatments, because future treatments for this disease will be targeting one of these changes. They're not going to be treating all the behavioral FTD. The genetics, there are 3 major genes causing behavioral variant FTD: progranulin, MAPT mutation, C9orf. So these genes are increasingly being tested in most patients presenting with bvFTD. So most patients that have a genetic form will have some cases in their family, but not all of them. So let's go into the treatment approaches. So first, I'd like to say a few words about dementia prevention. So this is not FTD specific, but there is a good news, which is that while we're seeing increasing dementia cases worldwide because of aging of the population, we are seeing that in higher income countries, the US, Canada, Europe, there's a decline in the incidence. So the proportion of people who develop dementia is going down. And that is because we better control risk factors like hypertension, diabetes, less concussions, less smoking. So while we're still seeing more and more cases because we have an aging population, the risk per person has gone down through these measures. So there are some studies that have looked at how many cases of dementia could we prevent if we were optimizing our management of risk factors. So they came up in analysis with a number of 35%. So there's 35% of the source of dementia that is potentially modifiable. That includes smoking, treating depression, increasing physical activity, breaking down social isolation, treating diabetes, reducing obesity. There's some studies that show that hearing impairment can cause dementia, so you can correct that with hearing aids. There are some early factors like increasing access to education, which has been shown to reduce the rate of dementia. So there are a lot of potential factors we could intervene on. So this is based on looking at what we call epidemiological studies, so large population study. If we look at it from a more restricted point of view, like studies, like are there studies that really show that you can do something that changes the outcome for the patient? There was a report from the National Academy of Medicine that looked at this. Their conclusions were, if we go at what has the most bang for your buck, it's controlling blood pressure. So patients with hypertension, very important to treat because you reduces small strokes that often trigger dementia, and increasing physical exercise, all type of physical exercise, including resistant training like weightlifting. For all cognitive training like online games or training, it's not bad to do them, but it doesn't tend to change significantly the outcome for patients. These are prevention that mostly reduce vascular dementia and Alzheimer's disease. Unfortunately, for FTD specifically, there's no current FTD specific prevention measure. I've mentioned that there are some studies that show that concussions could lead to earlier age at symptom onset. So could there be that target reducing concussion? But that's already part of public health measure. So there's not a lot to add from a clinician if you talk about pure FTD prevention. But we do encourage the vascular control. So let's go into behavioral approaches. So what I mean by behavioral approaches are all the non-pharmacological strategies. So when we're seeing symptoms that can be difficult to manage, what can we do, the family, the healthcare personnel, healthcare systems, to reduce the consequences of those behavior without necessarily prescribing medications? there are some recommendations that for a clinician should be part of all counseling around the initial diagnosis. So as a clinician, you see a patient, you do the evaluation or brain scans, maybe genetic testing, sometimes lumbar puncture. You conclude that this patient has probable behavioral variant FTD. What are things you want to say right at the onset to try to decrease the burden? One point that is often a difficult conversation with families is that we need to prepare right away for the unavoidable deterioration that we will see over time. And one part of this are legal documents. So that will obviously vary depending on jurisdiction, but everything around wills and power of attorneys, healthcare proxy, you want the patient to do this while they're very early in the disease so that they have the mental capacity to do it in a valid legal way to avoid running into issue when you're going to be in 3 years and now the patient is rendered incapable by their disease. It's much more complicated. So it's a difficult conversation, but you want to do that right at the beginning. Unfortunately, sometimes even in bvFTD, when we do the initial diagnosis, it can be already too late. So that's a good advice, like in general for the population. You want patient to be connected with community organisms and social services early in the process. So at the beginning, sometimes families will be able to manage on their own, and that's incredibly helpful to patient. But I prefer to connect patient and their families quickly with social services so that they're ready to intervene when the patient deteriorates, as opposed to, again, being in an emergency situation where the patient, for example, cannot stay home anymore and there's nothing that is prepared. So that can be the AFTD. However, our social services organized locally, so their day programs can be useful, residential services for more advanced disease. Another challenging conversation is around driving safety. So driving can be a major risk, both for the patient and for the public, in patients with poor judgment, poor impulse control, executive dysfunction. So that should be part of all initial evaluation, questioning the family around driving safety. The patient, because of the lack of insight, often will not be a very reliable historian. So try to ask for objective things where there are violations leading to speeding tickets, minor accidents, and you want to either have the patient do an on-road driving test early in the process, or sometimes, unfortunately, remove license when you think that judgment is severely affected. In general, we also always encourage patients to exercise, mobilize themselves. So in dementia, it's very important to continue to exercise the body for two reasons. It's good for the brain. So you're maximizing your chances of decreasing the rate of progression, but also it's very important to maintain muscle mass and balance, because when you start to have falls later down in the disease, that's often a major cause of deterioration. So patients can be admitted because they break a hip, they get worse, and they never quite recover. So as much as possible, we try to encourage it within what's possible with patients. So obviously in bvFTD, there are a lot of patients that have important apathy. So they're they have very low motivation, initiative. So you don't want the family to burn through their energy and burn out by trying to force a patient to go for a walk. But as much as possible, put something in place that facilitates this for the patient. Then the other very important piece is to have an in-depth conversation with the family caretakers. So ideally in the absence of the patient, so that the family feels comfortable to share their experience, ask questions. It's very important to understand the involuntary nature of the behaviors due to lack of insight. So early in the disease with bvFTD, the personality will start changing. There are going to be some behaviors that are questionable, and then family will initially naturally interpret this as the person being critical, the person being indifferent, the person being depressed, the person being disengaged from their couple. Family will look for a psychological explanation. Eventually, it progresses enough that they seek medical attention, and then we can say this was all caused by bvFTD. But it's hard for family to understand that in bvFTD, the patient has no insight into their disease. That is, that they're really not realizing that they're changing and that their behaviors are abnormal. They're not doing this because they're bad people, because they're angry at their family. It's really a neurological phenomenon. It's also not a psychological denial. So that's often an explanation that family will generate, that, oh, the patient just don't want to see it because there's something traumatic about it, and that one day they will have the illumination and realize it. No, it's a brain problem and it's never going to change, and nothing that the family will do will reverse that. So any effort that was directed at this need to be removed to preserve the energy of caretakers. That often leads to the next step, which is grieving the premorbid personality. So even though the person is alive, they're physically present, they can be demanding, it is not the same person anymore in terms of core personality aspects. And that is a very hard process to go through. It's equivalent to a grief, but you have to do it while the person is still around. So you want to support family in that process. Another very important concept is pick your battles. So there are a lot of symptoms in bvFTD, a lot of disturbing behaviors. So if caretaker wants to try to change everything, they want to make sure the patient moves, that they eat, that they go outside, that they socialize, that they don't do this behavior that they find disruptive, they burn out because it tends not to work. So when there's a behavior, you want to differentiate something that is causing distress to the family that can be annoying, but that is not distressing the patient and not causing them any harm. For example, I have a patient who likes to pick leaves in the backyard. So as soon as there's a leaf on the grass, he goes outside, he picks it up, he brings it back. So this is an example of a behavior that is harmless for the patient, actually makes the person walk. So it's not something that you want to invest effort into changing. Try to look for things that can maximize quality of life. So if the patient likes to take walks, you don't want to restrict that too early. So tracking system, medical alert bracelet is something we have in Canada. I don't know if it has the same name in the US, but bracelet to say that they have a dementia, so that if they have some unusual behavior on the street, they're arrested by the police, it's going to be evident and they'll be brought back home. So that you don't restrict the patient too much at the beginning. Also, you want family to involve their extended network of support. So community organism, but also extended family. So you want to quickly break the shame about the diagnosis. I encourage patients to talk about it, share it with family, so that bring siblings, children who might be living a little bit further away, so that they start helping out, so that the primary caretaker does not burn out, and also provide documentation, including the excellent resources from the AFTD. When there's a specific behavior that is disruptive that you want to try to improve or change, we apply principles of behavioral management. So maintain an environment that is structured and predictable. These patients do not do well with changes of place, changes of routine. So obviously it's never perfect, but try to have a routine that is very predictable. You decrease surprises and the risk for behavioral explosions. Provide cues for behavior that you want to encourage. So for example, patient has some challenges with hygiene, bring out the clean clothes that you want them to wear so that they visually see them to encourage them to wear them. On the opposite, remove the negative environmental cues. So for example, the person is not supposed to drive, but they're impulsive, they like judgment, hide the keys, hide the car so that they don't visually see it and get agitated because they will want to go use it. What's the simplest and the best strategy for most behavioral symptoms is distraction and redirection. So patients with FTD, they can get into a loop of thoughts or behavior, and you don't want to try to argue with them or try to reason rationally to explain to them why they're wrong. This is never going to work. So try to bring their attention to something more positive. So trying to use another topic they're interested into or soothing stimuli like music, old pictures, like something to shift the attention of the brain to something more positive so that they stop engaging in the more negative behaviors. Also, in more advanced disease, when you're communicating with the patient, offer simpler choices, factor language deficits, and we've talked about primary progressive aphasia. The patient has difficulty understanding simple words, simple sentences, visual images, what you want to eat, you can show different things to facilitate communication. For clinicians, so doctors, nurses, psychoeducators working in the field, when we try to find an intervention for a symptom, we refer to the ABC model. So the ABC model is simply a structured way to document problematic behaviors so that you can find what's causing them and how can we maybe change the pattern, avoiding medications. So A is for antecedents. What happened just before? So let's say the behavior is agitation. The patient starts becoming angry, yells, paces, throws objects. So there's agitation. What happened just before? Was there something maybe physical? Maybe the patient has pain. Maybe the patient wanted to go to the bathroom and didn't have access in time. Maybe it's something intellectual. They were trying to do something, their executive capacities weren't allowing them to do them. They got frustrated. Emotional, maybe someone said something negative to them. They were confronted with a bad memory. Sometimes it's their capabilities that can be physical. They were trying to do something, they were not able, they got angry. The environment, was it too noisy? Was there too much light at night? Too many people in the houses? And finally, social, like these patients can have difficulty tolerating big groups, a lot of people talking. So this will vary a lot from patient to patient, but when you're trying to decrease a behavior, do it multiple times. So every time it happens, what happened just before? What was the behavior in very concrete terms? And then C is for consequences. How did people around respond to the behavior? So how did the family respond? How did the staff respond if it's on an inpatient unit? Because there can be issues there. If the patient is bored because they're alone, they get agitated, the family comes in and spend time with them to decrease the agitation. then there was a reinforcing behavior. So you want to try to implement individualized interventions that are based on either removing some of the causes, say it's too noisy in the house, can we decrease the amount of noise, and improving the response. So making sure that behaviors that should be ignored are ignored, or that there's not a harsh response that is causing an increase in the agitation and the anxiety. So we always try to use non-pharmacological approaches first because you avoid side effects, they tend to be more effective in the long term. But because symptoms are so severe, we often have to use various medications. So currently in FTD, the sad news is that there are no disease-modifying treatments either for sporadic or genetic FTD. So we don't have a medication that can help with core FTD symptoms. So neither slow down the disease nor improve some of the cognitive symptoms. So we don't have the equivalent to the Donepezil or memantine we have in Alzheimer's disease. In FTD, we really have nothing specifically for the disease. What we do have are a number of pharmacological treatments that we use, what we call off-label. That means they weren't formally studied and approved for this indication, but we use them based on their properties to try to reduce neuropsychiatric symptoms due to dementia. The positive, and we'll go over it a little bit more at the end, is that there are a lot of active studies trying to study medications for neuropsychiatric symptoms, but also disease-modifying therapies, particularly for the genetic forms. So what are symptoms we can see that we can treat with medications? So there's some that are specific to FTD, disinhibition, hyperorality, compulsions. There are also a lot of symptoms that we see across all dementias. So apathy, agitation, psychosis, that means a break with reality. So either bizarre beliefs or hallucinations, like hearing things that do not exist. We can see depression in FTD. It's often hard to differentiate from apathy, but in depression, there should be more suffering, sadness, inner distress, as opposed to apathy, where it's really more a blissful indifference. There can be sleep disturbances, so insomnia or inversion of sleep-wake cycles. That's very challenging for families because it decreases their sleep quality. And finally, sexual disorders, often sexual disinhibition or inappropriate behaviors with other patients or relatives. The pharmacological management of, I write here BPSD, that's an acronym for behavioral and psychological symptoms of dementia, so all these psychiatric symptoms I just showed you. There's some key principles before initiating a treatment. So treat only symptoms that are distressing for the patient or have a significant impact on the family. So it's not because there is a psychiatric symptoms that you have to do something. For example, apathy. So in apathy, the patient has low motivation. So they maybe do not do much during the day. Maybe they sit in front of the TV for many hours, but during that time, they're not agitated. They're not wandering away from the house. They're not preventing family from doing other essential activities. So that could be a symptom that you could just explain, understand, educate, but you don't necessarily have to medicate. The treatment of those behavioral symptoms, as I mentioned, is off-label. That is, we're not guided by high-quality studies that really tell us which dose, how effective it is. So it's really based on clinical experience and looking at data in other diseases like Alzheimer's. We always start with low doses and we increase progressively until either it's very efficacious or there are side effects that prevent us from continuing the medication. Another important concept, every few months we should review if it's still required, because these behavioral symptoms, they go on and off, they fluctuate. So every 3 to 6 months, it doesn't mean stop the medication, but ask yourself the question, Is it still required? Was the medication really effective? Could we do a gradual taper to see if it's still required? And beyond choosing the medication, what's most important is to be very systematic. So one medication at a time, avoid piling up medications and then you don't know at the end what worked or not. The classes of medication we use. First and second generation antipsychotics. So these are medications like risperidone, quetiapine, brexpiprazole. These are medications primarily for psychosis, but they also work for agitation and insomnia. We do have some positive data in Alzheimer's disease, so commonly use low doses of risperidone, quetiapine. It tends to work for agitation, not as well for psychosis in FTD, but they do have neurological side effects. So they can create rigidity, tremors, they can be associated with weight gain. And there's some data showing even a tiny increase in the risk of stroke and death in patients with dementia. It's a small increase in risk, so we do still use them, but this has to be factored in the choice of treatments. The whole category of antidepressants, we use them for anxiety, depression. We also use them for agitation, and they can be modestly helpful for compulsions, the ritualistic behaviors. Medications, we commonly use citalopram, escitalopram, trazodone, venlafaxine. Particularly for trazodone, there is one positive controlled study that showed that it helped for agitation, so it's often a first line for agitation. And there's a little bit less side effects than antipsychotics. For some symptoms like compulsions, sometimes they help, but it's pretty modest. The group of anticonvulsants or mood stabilizer, drugs like the valproex, carbamazepine, lithium, pregabalin, they can help with agitation, anxiety. They can be combined with other classes, so we can use them with antipsychotics, with antidepressants. Some of them do require monitoring in terms of blood level, periodic blood tests. They tend to cause weight gain, and they have a lot of interactions with other drugs. Benzodiazepines and Z-drugs, so these are short-acting medication for anxiety, insomnia, and agitation. So these are drugs like Ativan or Lunesta. They do work well for sleep in the short term. In the longer term, there tends to be tolerance. The patients get used to the drug. There's an increased risk of falls. There's a negative impact on cognition. So we like to use them on occasions. We try not to give them as a regular daily medication. The class of psychostimulants. So these are medications for ADHD like methylphenidate, so Vyvanse, Ritalin. There's some data that it helps a little bit with apathy. Mostly it makes patients more awake, but the efficacy is rather small. It didn't really change much the quality of life, and it raises blood pressure. So we sometimes try them, but the improvement is not very important. There's not a lot that helps with apathy in terms of drugs. There's some drugs that work on the cannabis system, something called nabilone, that has one study that helped for agitation in Alzheimer's. So it's starting to be used, but there's no current study on FTD. We are doing one at our center to see if it works. There's a new group of medication called dual-acting orexin antagonists. So these are insomnia medications. There's lemborexant, suvorexant. So these are new drugs for insomnia. There's some study that showed they're tolerated in patients with dementia. They don't cause falls, and they don't seem to have a negative impact on cognition. So they seem like good treatments for issues around waking up at night or reversal of sleep-wake cycle, but these are very new medications, so there's limited experience in FTD. Other more unusual treatments, in more extreme cases of sexual disinhibition, there are medications that can block testosterone that we can try. And finally, one important point, all the drugs for Alzheimer's, the Nepazil, galantamine, memantine, do not have a role in FTD. There's one clear study with memantine that showed that it does not work. So they don't tend to make patients that much worse, but they're not helpful, so we do not prescribe them. We'll finish very quickly with what can we expect in the future? So as I mentioned, there's a lot of active studies. There's some large cohorts that follow patients with genetic FTD, sporadic FTD. There's some studies that are trying to look at new treatments for psychiatric symptoms. So I mentioned our study of nabilone for agitation. There's one trying to look at oxytocin, the hormone involved in human bonding, for apathy. So there could be some improvement there. There's a lot of excitement around future therapies for genetic FTD. So there's some therapies that can correct the deficits from progranulin mutations. There are compounds called antisense oligonucleotides that block the toxic effect of some mutations. There are even some viral vector gene therapy where you insert some DNA material in the brain to produce proteins to compensate for the loss of function for the mutation. So most of those are still early stages, but there's a lot of hope that in the next 5 to 10 years, there could be some pretty significant treatment to modify the course of patients with mutations. Unfortunately, there are much less studies in sporadic FTD, and a lot of this is caused because it's a complex disease in the brain. There are many different causes pathologically of sporadic bvFTD. So it's very hard to do a trial because you don't know if the patient has TDP43 or tau in their brain. We don't have currently tests that we call biomarkers that can reliably tell us that. But that is also an area of research, trying to be able to predict in my individual patient, what can I expect is in their brain, so I could eventually include them in a clinical trial. So I will stop here for the presentation so that we have time for questions. So I thank you for your attention, and I'll be happy to answer any questions you might have.
Thank you so much, Dr. Ducharme. I really appreciate your considered and thoughtful discussion of non-pharmacological treatments and the importance of clinicians to work with families to really educate them around the value of those interventions. As well as, I know personally, I learned a great deal in your overview of pharma treatments and when and how to determine their best use, but to use them in conjunction, if needed, with other interventional approaches. So we've had a number of questions come in, and they're kind of very wide-ranging, but I'm going to try to encapsulate some of them as we go along. So I think one of the first questions that I'll ask you, and going back to sort of like your initial discussion on some of the risk factors with dementia in general. And I know there's not a lot of specific FTD research, but it's going back to the age of onset of bvFTD or FTD, how early, and then also how quickly deterioration occurs over time. And so speak again about anything you can say about what seems to drive that, and if you again feel that it's always helpful to implement lifestyle factors in relation to that.
Yeah. So the age at onset can vary. The youngest cases, maybe they go at 35. There's some more extreme cases, but usually it's after age 40. It's very mysterious why the process starts at that age. We better understand the cascade. Like once the abnormal changes in the brain start, we understand how they progress, how they go from one region to another, how we can predict how the brain shrinking will evolve, but we don't have a good understanding of the initial trigger. It's a hard population to study because it's not as common as Alzheimer's. So in cohorts where we try to identify risk factors, there are not that many cases that you can really robustly say, oh, it was this risk factor or that risk factor. So it's very mysterious why patients without genetic mutation develop this. there's probably some degree of complex genetic risk factor that is not a mutation we can test for, but that predispose the patient. It is important to implement the vascular prevention, particularly at the beginning. So it's not because you have FTD that your brain is not influenced by mini strokes. So if you have a disease that is progressively getting worse, everything you can do to minimize other sources of damage is helpful. So particularly blood pressure control, diabetes, like often these patients will eat, gain weight. So you want to make sure you do the blood test periodically to see their cholesterol issue, diabetes issue.
Okay. And in terms of FTD research, I I think you've already alluded to the fact that there's more research going on. There's hope in the field. There's a special interest in genetically related FTD and their opportunities in terms of discovering effective disease-altering treatments. Um, uh, when you are seeing a patient and family, what and you're a researcher and a clinician, so what's your approach to the topic of genetics and genetic counseling and genetic testing? And I know that you live and work in Canada, so there may be some distinct differences, but what could you say about that for our audience?
The approach to genetics has evolved. It used to be that we would only test patients with very clear family history. So we always ask, like, is there someone else in the family that had FTD, young onset dementia, young onset Alzheimer's, because often diagnoses are not that reliable, ALS, which is genetically related. So if there are many cases in the family, well, obviously you're going to go for genetic testing. The change that we've seen recently is that, particularly in behavioral variant FTD, we do find mutations occasionally, even in patients that do not have family history. So if a patient has no family history, there's about a 5% chance that you do find a mutation in often the C9 chromosome expansion. So there's more and more a movement toward testing genetically all patients with behavioral variant FTD. So that will vary from site to site. At my site, if you have confirmed bvFTD, you will get genetic screen. For patients, it doesn't currently change management because it's mostly improving symptoms. It can make them sometimes eligible to a research medication trial. We do this mostly for the counseling of the family, because if there's a mutation, there's 1 out of 2 chance that every children from the patient will have it. And we think that's information that's very important for our family to know, for their own personal decision to say, I want to get tested or not, to know if I have it, to be aware of what's coming in research, participate to research cohort. So I would say there's a movement toward more genetic testing.
So thank you for that response. I just want to mention for our audience that AFTD has a genetic page, FTD and genetics, on our website. If you go to theaftd.org, you'll clearly see a genetic tab. There's lots of great information to help families better understand FTD and genetics, to also read about and think about the issues around testing and confidentiality and things that may impact, as well as guidance for how to find a genetic counselor. You can certainly call our helpline or email our helpline or go for information there. We do want families to have the information they need. We have just a minute left, and I'm going to ask probably a difficult question and give you a minute or less to respond. So one of our audience members talked about the balance of independence versus risk. And I think that families find that very challenging, and maybe even clinicians find that challenging. How do you help families to kind of sort that out in the journey of the disease?
Yep. So I will divide risk for the patient versus risk for the public. So if it's risk for the public, like reckless driving, that we have to be very strict about, put measures in place to prevent it. If it's risk for the patient, so I would say the two most common ones are the patient who wanders or goes on walk or bicycle ride, and they're very regular about what they do, but they're starting to reach a point where maybe their capacity to explain themselves if they get lost will be challenging, or they might occasionally be intrusive with a stranger, the police might be called. So we're getting in that zone. When it's that type of risk, I aim to maximize the quality of life of the patient. So I usually encourage families to let those behaviors go up until we're really obviously reaching the point where it's getting dangerous. So it's a very concrete example of a patient of mine who takes long bike rides. He was very symptomatic, but he was doing it, and that was occupying most of his days. And he was coming back, so we're a bit uncomfortable, but the alternative was locking him in an apartment, which is no quality of life. So we let him go, and he did it for a few years. Now we've reached a point where, let's say in the last 2 months, he was arrested 4 or 5 times. Well, obviously he's crossing streets dangerously. Like, obviously we've reached a point where we need to restrict his liberty. But I think the approach of letting him do it for 3-4 years, as opposed to being too careful and saying, no, you stop doing that and then you're going to be miserable. These behavioral symptoms are very hard to treat. Now, one point I maybe didn't make enough in my presentation is that the expectations for reducing the symptom with medication, they have to be modest. It helps a little bit, but it's not going to take it away. So, we need to start to kind of live with them and tolerate some risk. And same also around food, like patients eating a lot of sugar, gaining weight. You try to restrict what you bring in the house, but there's a point where, yes, their diet is not going to be great, but currently that's what they enjoy, and let them have this quality of life for the next few years.
So I sense from the way you talk about these challenging issues that you're an active part in the education and counseling and support as part of the team that works with the patients and family caregivers that you serve. So we could talk about this much longer. We really, really appreciate you joining us today and speaking about these difficult issues. So we are going to move on, and I'm going to close out the program with just a quick talk about research opportunities. As you mentioned, it's so critically important that we have participants in research, and how can persons with FTD and family members find out about recruiting research opportunities? And it's quite simple to encourage them to check out the FTD registry at ftdregistry.org. It offers persons the opportunity to learn about research that's currently recruiting, as well as to share their research, their stories to help research design. And you should know that participants' personal information is never shared. Families and clinicians can also sign up for our AFTD newsletter at the aftd.org to keep informed about emerging research opportunities. And we certainly want you to stay tuned. We will be continuing to offer continuing credit education webinars for healthcare professionals coming later this year into 2024. Thank you so much for joining us, and thanks again to Dr. Ducharme for his informative presentation. Take care.